Hello, my name is Shawn D Teague, and I'm an Associate Professor of Radiology at National Jewish Health in Denver, Colorado. Today I'll be presenting a non-ischemic cardiomyopathy case. The patient is a 74-year-old man who presents for cardiac MRI examination. He has a history of dyspnea. He previously had an echocardiogram which demonstrated diastolic dysfunction and a cardiac catheterization with no significant coronary artery disease. He has also had a prior procedure involving his kidney, but he is unsure about what the procedure actually was. We can see here from his cardiac MRI that there are bilateral pleural effusions as noted on the scout image on the left. Looking at the four-chamber view on the right, you can see again the bilateral pleural effusions, as well as thickening of the interventricular septum, especially at the basilar aspect. There's also a trace amount of pericardial fluid noted posteriorly. On this stack of short-axis cine images, again we can note the thickening of the interventricular septum. The left ventricular function is upper limit of normal, calculated at 70%, and the right ventricular function is lower limit of normal, calculated at 48%. The ventricular chamber sizes are normal bilaterally. On this static short-axis image, again we can note the thickening of the interventricular septum measuring up to 2 centimeters in thickness, comparing that to the posterior wall where it measures 8 millimeters in thickness. The normal thickness of the myocardium is up to 12 millimeters in thickness. Finally, on these delayed enhancement images, we can see the image on the left is the TI scout set of images. You can notice that it's difficult to identify a good TI time that results in nulling of the myocardium. The delayed images on the right demonstrate that the myocardium is the darkest when the blood pool is also dark. Normally, the blood pool should be bright when the myocardium is best nulled. In this situation, the gadolinium is being rapidly removed from the blood pool. This results in the myocardium nulling before the blood pool on the TI scout images, making selection of the best TI time difficult. Phase-sensitive inversion recovery, or PSIR images, can be helpful in this situation, given that they are independent of the TI value. So our final diagnosis in this case is cardiac amyloidosis. The appearance of the TI scout images and difficulty picking the best TI time are probably the most useful in making the diagnosis. If you see diffuse subendocardial delayed enhancement, it is pathognomonic for amyloid, but this pattern is not very common. A more diffuse, patchy pattern of delayed enhancement is much more common. The differential includes hypertrophic cardiomyopathy. The ventricular function is usually normal to mildly reduced with amyloidosis, whereas with hypertrophic cardiomyopathy, the function is often hyperdynamic. With sarcoidosis, the myocardium is often normal in thickness with mid-myocardial delayed enhancement. Hypertensive heart disease is secondary to the elevated heart pressure due to hypertension. More rare etiologies could also be considered, such as glycogen storage disease. With cardiac amyloidosis, there is extracellular deposition of beta amyloid protein. The accumulation of the protein can result in pressure atrophy of the adjacent myocardial fibers. There is involvement of not only the myocardium, but also the valve leaflets and vessels. Cardiac amyloidosis is the most common cause of restrictive cardiomyopathy. In fact, restrictive cardiomyopathy is the leading cause of death in approximately 1/2 of amyloid patients. Diffuse enhancement can be seen not only in the left ventricle, but also the right ventricle, intraatrial septum, and atrial walls. The enhancement pattern is often somewhat diffuse and patchy. There are altered T1 kinetics resulting in nulling of the myocardium before the blood pool, which results in difficulty identifying the correct TI time using the TI scout images as we've previously discussed. The blood pool appears dark because of rapid redistribution of gadolinium out of the blood pool. There are contradictory studies showing the prognostic value of delayed enhancement. Therefore, delayed enhancement is probably better to help in making the diagnosis than for prognostic value. Not only can the ventricular myocardium be thickened, but there can also be thickening of the atrial myocardium. Again, when trying to differentiate restrictive from hypertrophic cardiomyopathy, the left ventricular systolic function can be helpful. In restrictive cardiomyopathy, there is usually decreased LV function, whereas in hypertrophic cardiomyopathy, the LV function is often normal to hyperdynamic. T1 mapping and ECV, extracellular volume, have shown promise in correlating cardiac function and risk stratification. Also, of note, cardiac MRI has shown promise in differentiating among light chain and ATTR subtypes of amyloidosis based on LV mass, as well as location and extent of delayed enhancement. This is important given the difference in treatment based on the amyloid subtype. Here are a few references for more information. Thank you for your attention, and I hope you enjoyed this case.